Good evening, everybody. Oh, you're a very compliant crowd. That was really fast. I didn't have to do this and get quiet. Thank you so much for joining us here tonight. I'm Jody Younger, and I'm the Vice President of Patient Care responsible for the mental health portfolio here at St. Joseph's, as well as quality for our organization, and I'm really glad to kick us off tonight and get to introduce our speaker. It's really important to talk about how do our mental health issues intersect with other types of illness such as dementia. And I know that's why you're here tonight. And a lot of people don't understand, especially if you don't have that in your life, that when we care for people with dementia, there's a very high caregiver burnout. And that's also very important to look at. It also results in secondary depression and mental wellness and health issues among family members of those caring for people with dementia. I'm a person who's been passionate about mental health my whole career. I'm a clinician, I'm a leader, but I'm also a caregiver of somebody with dementia. So I know personally how difficult that can be for family members sometimes. I have a personal connection to that. So now introducing Dr. Burhan. He's a geriatric neuropsychiatrist and the physician clinical lead for the Therapeutic Brain Stimulation Program at St. Joseph's at Parkwood Institute. He also runs the Neuropsychiatry Clinic for patients with psychiatric presentations of neurological illnesses like Parkinson's disease, and also associate professor and chair of geriatric psychiatry at Western University. So I'd like to welcome Dr. Burhan to the podium to talk a little bit today about Beyond Memory, how Alzheimer's and other dementias affect mental health. Thank you.
Thank you for the introduction, Jody, and thank you very much for being here. This is a great opportunity for me to share a story in terms of how we're trying to deal with a very important public health issue, both the cognitive disorders, but also how mental health and cognitive disorders or dementia and related illnesses like Alzheimer, how do they interact, both as a risk and how they affect each other. It's amazing to see so many of you in a frosty night like this, but so I'm going to start with a bit of a chilling news about the interaction between mental health and dementia, but hopefully things will warm up as I explain to you some of the solutions that we're working on. So I'm planning to do this, discuss the effect of Alzheimer's disease and related illnesses like dementia on emotions and behavior in the person and the family that going through that journey. Discuss the current treatment options we have, but also looking at the research opportunities that are shaping the understanding of these issues, but also how do we treat them. So hopefully that will all at the end come to some clarity. So the story of Alzheimer, as you know, started with this man who was a German psychiatrist who was very interested in knowing the underpinning of mental illness. So the motivation of looking at the brain was to try to find the cause or the reason why people develop this disturbance of cognition and mental function. And he actually described the first case of Alzheimer, and it wasn't until the father of modern psychiatry, Emil Kraepelin, who Alzheimer worked with, he actually described the illness and called it Alzheimer after the man who described the first case. So he was a very humble scientific man who wanted to understand, and he described this case. So Augusta D, or we know now her last name was Dieter, who was the first patient described, and she was quite young. She was only 51-year-old when she presented to the asylum, and as you know, the asylum in those days was the place where people with mental illness and other illnesses that look like mental illness, syphilis, tertiary syphilis used to be a place where, an illness that goes to the asylum, Alzheimer's disease and similar illnesses. So Augusta presented with the problem with memory and language, which is what you would know about Alzheimer's disease, but she also presented with behavioral changes. She had a lot of issues with disorientation, but hallucinations and behavioral problems. She was agitated, and that was a very early description of this illness. And of course, Alzheimer did look at her brain. It was part of the deal with the family that he's going to take care of her, but also that if they can donate her brain for him to understand. And we still do this in modern day work to try to understand these illnesses. So he actually described the very first pathological finding in Alzheimer's disease, the tangles and the plaques that are continuing to be the hallmark of Alzheimer's disease. So I wanted to spend a minute just to describe the difference. I mean, a lot of people still ask me, what is Alzheimer, what's dementia? And sometimes it's not clear to people that dementia is really an umbrella term for a lot of illnesses, and Alzheimer is the bigger kind of member of that group. So we look at the percentages, so about up to 75% of the time dementia is Alzheimer's disease. But a lot of time when you look at Alzheimer disease, you find other pathologies like vascular pathology or Lewy body. So those illnesses can happen alone, like say you can be a pure vascular disease, but it's more common for the illness to be Alzheimer plus. And I'm sure that some of this was last year talked about by Dr. Bori, who's a colleague of mine from genetic medicine who does a lot of the work on the cognitive part of things. So I just want to make sure that this piece out of the way before we move forward. Dementia in general is a international problem. It's a global disease. This is a report from 2015 that showed that every 3 seconds we have a new case of Alzheimer being added internationally and globally. Very, very serious illness. Actually, growing economies are place where Alzheimer is increasing. As you know, people are now reaching the old age in places that didn't have that luxury before, like India, China, and so you start seeing places that economies become so good that people can live longer, and now you start seeing it. We saw that before in this kind of society. So age has something to do with it, and I'll explain that relationship a little bit. But it's a very costly disease. It's, if you put the cost of Alzheimer's disease, it matches the 18th largest economy in the world. So it's very, very expensive disease, and by 2030, it's going to cost about $2 trillion. So it's a huge global burden. Now, what's age had to do with the dementia in general? Well, we know that in Canada, when you look at statistics in Canada, by 2036, 1 out of 4 Canadians will be above the age of 65. So we know that our population is, in general, aging. And if you look at what happened to the risk of dementia, 2 out of 10 people will develop dementia at that age, at 65 and older. Now, by 2020, we have 1 out of 5 Canadians will be above the age of 80. So we know that section is also growing. And if you look at the rate of dementia, it's actually almost 1 out of 3. So it's a very serious. So if you're sitting next to 2 people, one of you will have dementia by age 85. The good news is the one next to you. Yeah. So it's always you can all. I mean, the fact that you're. But it doesn't have to happen, right? There's 2 people that don't have it. So we need to think about how can we enhance the chance of people who maybe are destined to have it, but they can push it by some few years, and how do we delay the onset of it? How do we actually slow it down when it happens? How to maintain? So you probably heard from Dr. Bori and his work on the cognitive piece, what they're doing in that area. I'm going to focus on the mental health component. Now, as you know, most of us will have cognitive aging that is considered normal. You speak to anybody who's aging in a normal way, they will say that, I don't think as fast as I used to. I can't think about too many things at the same time. I forget where I parked my car. So these are things that will happen to all of us. And there's an acceptable level of normal aging, normal cognitive aging. But sometimes you see that curve changes and people start crossing the line to something we call mild cognitive impairment, where now it's not the usual cognitive aging. So now there's a detectable change in memory function or cognitive function compared to a person who's at your age and educational match. And in that state, it's not a dementia yet, because the person still can function, they still know a lot of things, and they can do everything basically except for a very high complex task. But then that is a risk state to develop dementia. So this is an important thing to consider, because if you're normal, we want to try to prevent you from crossing to mild cognitive impairment. And if you're in that mild cognitive impairment, we want to prevent you from crossing to dementia, right? So you can see that the intervention potential is throughout that spectrum. We can't consider once you get here, you're done. Or even when you get here, how about if I can keep you in a milder form of this so that you can continue to enjoy, and family and loved one enjoy you being there and enjoy doing things with you. So we can't give up. This journey could be long, and we need to find a way of actually helping people throughout that journey. And I'll share with you how that is relevant to mental health. So mental health and dementia. So we are going to today talk about the mental health issues as a risk to develop dementia in the future. So not part of the illness, just the fact that you had a mental illness such as depression, bipolar, schizophrenia. Is that something that will increase your risk to develop dementia? And I'm going to share with you what we know today. And is it an early sign? So let's say it didn't happen to you, but then in your late 60s, you start developing depression. Is that a first sign of dementia? And how do we know the difference and what should we do? And then if you have a diagnosis of mild dementia, is it going to accelerate the course of the illness, going to make it faster? And then also, as part of the illness, part of the symptom that you have to deal with. So I'm going to go through this step by step, explaining how is it a risk, how is it early sign, how is it going to change the course of the illness, and then if it is part of the illness, what we're going to do about it. Is it making sense so far? Okay. All right, so as a risk factor, so here when you talk to a psychiatrist, I have my site chief here, Dr. Northcott, who actually presented on mental health. If you talk to a psychiatrist, say you're seeing somebody in your clinic and they're nowhere near dementia, you don't have to worry about that. It turns out that this is an Australian study that says if you see people in middle age and they have schizophrenia, they're 12 times more likely to develop dementia in old age. So this is separated by several years, by more than 10 years. So it's not, it's not the beginning of a dementia. It's just the fact you had that illness that will put you at a higher risk in the future. So this is an opportunity we don't know today whether can we do something to prevent primary prevention, meaning you stop that illness from happening 10 years from now or 20 years from now. People who have bipolar illness, about 4 times and a bit higher than the average to develop dementia. Alcohol, 4 times higher. And they put diabetes and head injury to show you that it actually sometimes beat illnesses that are quite significant. Diabetes affects the brain metabolism, head injury, direct insult to the brain. So things like depression is kind of 2.5 times more likely. This is one study. I think more studies confirmed that. So mental illness in middle age actually put the person at risk of future development. The question that we have to answer today, could we treat this illness more aggressively and try to stop people from living with the mental illness long to damage their brain? Because we think, and I think a lot of the psychiatrists, hopefully mental health professionals will agree with me, that when you are in a state of mental illness, like depression, like psychosis, there is a damage happening to your brain. And that damage, it's probably dose dependent, meaning that the longer you spend time in that state, the more likely you're going to get insult on your brain. And we are studying that as we speak. There's a study that I'm going to share with you that we're looking at ways of understanding what's the impact of illnesses like chronic treatment-resistant depression on brain function and how is it damaging the brain. Okay? Now, moving on to, when you see depression within 5 years of a developing dementia. So that kind of tells us that it's not necessarily a risk for future. It's probably part of the same illness. So there's a lot of studies that looked at people in the old age. For example, this is from Western Australia, looking at about 5,000 men, actually in this case, because they were doing a study related to men's health. And they found that if you follow people for 14 years, those who have depression seem to be at high risk of developing dementia, mainly in the first 5 years. So mainly closer to the onset of this. So the question is this an incipient, meaning that this is a first sign of breaking down of emotional network. So it actually may show up before memory problem, before language problem. And as a geriatric psychiatrist, if I'm sitting in my clinic and I see somebody who says, I never dealt with depression before, but now nothing really major happened. I start feeling very upset because I couldn't sell my house when the market was high. And then I'm going to give you a real case that I've dealt with. A person who is very well, did work hard, had good retirement plans. The market changed and he didn't sell his house. And he thought, you know what, we're going bankrupt here because I should have sold my house. And his family was telling me, we have no concern whatsoever about finances. We have a lot of money. We're not going to even spend our money by the time we die. but he had this depression and psychotic belief that he's poor. Now, he didn't develop this illness till his late 70s. So the question for me as a geriatric psychiatrist, why now? Why is this happening now? Because this person have shown a lot of resiliency all his life. He dealt with probably so much more than this. So then I would follow up with this person to see if he's going to develop cognitive change within the next 5 years. And I usually do not wait for that to happen. I treat aggressively depression, because even if I cannot prevent the dementia, I think in a lot of cases we don't, but maybe we can delay it, but also give this person the best quality years before they develop illness that may actually get them to lose their cognitive function. So it's not only prevention, which is not for disease not to happen, it's also improving the quality of people's life and everyday matter. And we treated that person with medication, did not respond enough. We went to electroconvulsive therapy, which I'll share with you, and he recovered completely. And he, this is a very interesting story. He actually showed mild cognitive change, but he did not develop dementia. And unfortunately, he died of a dissected aneurysm, which came out of nowhere. We didn't really expect that to happen. So his family asked me very legitimate questions, say, is there anything you've done that could have created this? And truly, there's nothing that I could have predicted. I mean, we treated him well, tolerated the treatment, was out of depression. And in fact, the night before he had that event, he went dancing. And, so then his family wrote me a nice letter and said, we know we're sad that we lost our loved one, but you gave him the last few years of wellness, because he was sick for 5 years before that. So it's not just preventing, it's also giving better quality, right? So whenever we see depression, we treat, and we treat aggressively, want people to get better, and we use all the tools we have. The other thing that I want to share with you, that a depression in the context of somebody who carries some risk for Alzheimer's disease, for example, genetic risk. We know that there's some illnesses, like some Alzheimer patients will inherit a gene that will get them to have Alzheimer in a more predictive way. They call it dominant, autosomal dominant, but that's only 5% or less of people who develop Alzheimer. The majority of people with Alzheimer will not have any genetic risk. There's about 50% that may have ApoE gene, which is not a predictive gene. So it's not like you have it, you're gonna, if you have the gene, you're gonna have the illness. This is more increase your risk. It's a susceptibility, just increasing your chance. So if a person carry that risk gene, if they have depression, they tend to develop Alzheimer at a higher risk. So there's an interaction. So another example where depression create more risk of dementia in those who have the risk, but maybe would have survived it if they didn't have depression. Now, we don't know here if it is increasing the risk or is it part of the early manifestation of the illness. Now, moving to the next step in the spectrum, when somebody have mild cognitive impairment. So this is when a person shows signs of cognitive impairment. Again, if you look at the psychiatric symptoms in general, between those who have mild cognitive impairment in the gray here and those who do not have mild cognitive impairment, you can see that those who are not dealing with mild cognitive impairment, up to 75% of them do not have any psychiatric symptoms, which is what you expect. But this is a population study. So if I just ask all of you now to rate, do you sometimes feel down, sometimes feel anxious, I get that result. But those with mild cognitive impairment, up to 50% of them will have at least one or more of psychiatric symptoms. So we know that connection between cognitive impairment and behavioral symptoms. And again, when you have mild cognitive impairment and depression, more likely to develop Alzheimer's disease or dementia of any sort. This is example of what happens if you now compare those with mild cognitive impairment to people with dementia. Again, the story holds that people with mild cognitive impairment are more likely not to have psychiatric symptoms. Again, very similar to that slide. About half of them will have some psychiatric symptoms. But look at people with dementia, up to 75% of the time, they will have psychiatric symptoms. So psychiatric symptoms, emotional symptoms, behavioral symptoms, whatever you want to call them, and cognitive disorders are very closely linked. At the risk, as part of the early manifestation of the illness, as an accelerator of the illness. So what are these symptoms? Now that we kind of covered some of the risks. So we have something we call the Neuropsychiatric Inventory. And it's really, from talking to people over the years, experts sat together and say, what do we hear from people? So there's something that we call psychosis, which is delusions, hallucinations. So people sometimes mix up the two concepts. So delusion is when a person have false belief. Somebody is stealing my money, right? You go there, you look, oh, that person that you hired to help me clean the house is moving my stuff away, taking my stuff away. That's a paranoid type of thought. And no matter what you say, sometimes the person will not, change their mind about it. But there's other forms, of course. There's people think that, in fact, there's very dramatic forms when people think that they're being raped at night or somebody's trying to kill them. And of course, hallucinations would be when a person see or hear things that other people don't see or hear. So your brain makes things up. And that's part of the brain change that happens with these illnesses that create. And some of them, like dementia of Lewy body, is an example of a form of dementia where people see very vivid things. This is when a person says, I've seen a group of men coming to my room at night and trying to kill me. It's very vivid. And you know what? You cannot dispute that this person is having this experience. So the last thing you want to do to say, you're making this up, you're lying about it. Because they're not. They're actually seeing that stuff. And it's their brain that's creating it. And it's like you and I could induce hallucination by using drugs. I mean, why do people use drugs? They use cocaine. Sometimes you hallucinate. It's an experience that all of us could have. But in this case, it's coming from an illness that is affecting parts of the brain. Okay? So that's psychosis. And you see affective, which is more depression, anxiety, being irritable. You see agitation and aggression, which is more, we don't know where it's coming from. And usually it happens in the advanced stage of the illness when the person just roaming around, they're aggressive, you can't stop them from doing things, they can hit you. Some changes in behavior when a person just walk around and fiddle with things and keep moving things around. Nighttime problems, eating problems, and apathy, which is another whole ball game when the person just don't want to do anything. And you think that they're depressed. They say, no, I'm not depressed, but just, you can't get them to go out for walks or go for a meal. So all these are challenges that we run into in the context of mild cognitive impairment, Alzheimer's disease, different types of dementia. And it is a big, big challenge for families and for caregivers. I don't want to bother you with numbers, but just to show you that these symptoms that I described are higher in dementia, but they do happen in mild cognitive impairment. And they tend to change in character. So early on in the illness, like when a person has mild cognitive impairment, even before showing the cognitive change, they might show depression, anxiety. Typically, as the illness progresses, you start seeing psychosis where people start having hallucinations, delusions, or become agitated. So we see some pattern of change over time. The one thing that we also have to acknowledge that, unfortunately, the rate of these symptoms in long-term care facilities. So when, if you take what I showed you before was in the community. This is like people living in the community with mild cognitive impairment or dementia. But if you go to long-term care facility, we know that there's a lot of people that live with dementia in long-term care facility, and they have close to 80%, some studies up to 85% of agitation that happens. So this is not a casual problem. This is everyday occurrence in long-term care. So you have to think about and you all have heard all this bad news about people being killed in long-term care because somebody got agitated, pushed them, fell. So it's not a trivial problem. It's in the news. It's a big responsibility for the system to take care of, and we need to come up with better solutions. So in general, these symptoms, behavioral psychiatric symptoms, they're bad news when it comes to this illness. They impair quality of life. They add a lot of burden to caregivers, but also a system of care. In fact, our hospital emergency rooms and hospital beds are really full of people who are in need for help when it comes to this kind of presentation. And it does speed up the progression of the illness and increase the risk of death. And I'll show you a study that showed that where, this is an example of agitation and aggression. So people who don't have it versus those who have it. Those who have the agitation, they tend to survive less. So in this case, it's like surviving from mild to severe dementia. So basically, how many people who have agitation will progress to have severe dementia versus those who don't have? Those who have agitation will be faster to get to a severe dementia and faster to die. So psychosis, agitation, and aggression can make people progress faster to severe form of dementia. And psychiatric symptoms like psychosis, even depression, agitation can make people die at about 1.5 to 2 times more likely. So it's not a trivial thing. So we are in need to treat these if let's say somebody have mild form of Alzheimer's disease, if you know that treating these symptoms will help them stay in that spot longer, you want to do that. And they actually increase the chance of people to go to long-term care facility. So people living home, and you know how difficult it is for families to decide on actually putting their loved one in long-term facility. It's not an easy decision because you feel guilty about it. They tell you that you shouldn't put them there, and you promise me not to put them in long-term care. It's not a choice you're making. It's because of necessity. And some of the things that get you to do that is when somebody is physically aggressive or being so restless and wandering. And there's a lot of symptoms that will create that need to go to long-term care. So this is just to summarize what I spoke about. So mental health disorders or symptoms are risk for developing future dementia. They're part of the early signs of it within 5 years. They accelerate the course of it if they happen, from MCI or mild cognitive to dementia, but also accelerate the progression of dementia and cause more death. Now, that was a long discussion. Any confusing part I said here? Is it making sense still? Yeah.
A couple slides back, there was something that said NPSD. What did that stand for?
MP?
NPSD.
Okay. Neuropsychiatric symptoms of dementia. Yeah.
Okay.
Yeah. Just I know sometimes we get used to certain terms, and these terms keep changing. It used to be BPSD, then NP. So I'm glad you asked. Yeah. Okay. So now I want to come to talk specifically about the effect of caring for somebody with dementia on the family, right? So there has been nice studies. Brodati from Australia has been authority on this field. So the psychological burden, so affecting your mental health if you're caring for somebody with dementia. It's worse if you're a female spouse. You probably care more. I'm just saying. I'm surprised by it. So if you're a spouse, you care more. But I actually see situations where I couldn't understand. So a person who would have been very, bad person, did not treat their wife well, and they separated for years. And when they develop dementia, that ex-wife comes and take care of them. And I just don't understand it because he did not treat you well. I mean, I don't tell them that, but in my mind, I'm saying, why would you now care about a person who did not treat you well? But they do. Now, of course, if you have limited resources, the younger onset dementia is another story. I mean, when you see people who they should be now still working, they're going to retire in 5-10 years, and now they develop dementia. Like your whole plans are so it's a high risk of developing psychological burden. Behavioral symptoms accelerate and increase the risk of behavior, and of course functional impairment and incontinence, because that's another thing that changes the whole dynamic in your relationship. So these are things that people, when they're dealing with dementia, if it is just a memory problem, it's already a burden, but adding those components, it makes it even worse. And also, this is something that we became interested in, is physical burden in terms of what happens to the person's health. So poor overall health have been higher mortality. People who care for people with dementia are at higher risk of dying from illnesses. And we're trying to understand that. I think there's something to do with the lower immunity, self-neglect, sometimes obviously coping. You want to cope, you may drink more, you may not take care of yourself. So we work with families all the time to say, you are as important as the patient. I don't see just the patient. I see the family and I say, we're taking care of both of you here. What do you need? It seems that you're not taking care of yourself. You need to be treated for depression. These are things that you have to think about when you care. So we never have one patient. It's always more than one patient in the room. And of course, behavioral symptoms adds to the burden, as I mentioned. These are some of the symptoms that have been studied to show, like psychosis, anxiety, nighttime behavior, restlessness, disinhibition, eating behavior. We have people who say, I have to lock the fridge because some illnesses, like frontotemporal dementia, result in people wanting to eat more. And sometimes they have diabetes, and you have to stop them from doing that, and it becomes a nightmare. You're always locking things and chasing them not to eat more. And it's hard on you because you just think, well, they want to enjoy it, but I know they're going to raise their sugar and they're going to have more problems, right? So, and one thing I want to leave you with, that behavioral psychiatric symptoms are more predictive of burden on the family than the cognitive symptoms themselves. So if you look at, this study actually looked at that, the score on cognitive function versus the behavioral symptoms. Score on cognitive function did not predict burden. It was really the behavioral issues that predicted the burden on the family. All right, so now I'm going to move on to tell you about the framework. What do we do when we see a situation like this, which is obviously bread and butter of what we practice. So we start thinking about it now a little bit. So we used to be more crisis-oriented. You know, it's a crisis, you show up, you try to help people. But now we're moving more and more toward prevention. Could we try to give advice before the crisis happened, before the person, you know, show up in the emergency room with a crisis? Also thinking about general advice in terms of what do you do that's good for everybody, and what do you do which is targeted for the person themselves. So for example, you know, general engagement, activity, social activation, that's all good for everybody basically. But sometimes you say, that particular person is annoyed by the fact that they don't remember their appointment. Can we come up with a specific strategy to address that, you know, so it becomes targeted, individualized? And then the question about medication. So what do we do with medication? You know, what do we use? When do we use it? How long? What do we watch for? So all that stuff. So we need a framework. We can't, I mean, I started practicing in this field probably close to 20 years now, from residency till practice. And then in the beginning, it used to be, oh, we have great drugs. It's going to work for everybody. And then as my career progressed, we knew those drugs were bad news. And now we started, oh, we're not going to use any drugs. And then we end up discovering that we do need drugs sometimes. So it's a very difficult field to be in. We just starting seeing more consensus. A lot of, you know, and I'll show you some of what we have been working on. So this is a framework that published by Kales. She's from University of Michigan, the DICE model. It basically says, whenever you see a behavioral change in this illness, don't just jump in and give a medication. You have to start by describing what's happening. So who, what, when, where. Examples would be, somebody is getting agitated, and I get this consult. I go to a long-term care facility and say, yeah, Mr. So-and-so is agitated, and we can't care for them, you know, or for him. I say, well, what happened? We don't know. It's agitation. I haven't been here. You know, this is the first day I'm working with Mr. So you never get a straight answer. But I don't take that I go and ask. I say, well, where did it happen? Well, dining table. Whenever they sit with this particular person, they think that this person is a Nazi, and therefore they're aggressive. Well, did you think that maybe there's something in this person's history that created this? I mean, we have to think about the context and the history of a person. That particular person ended up being somebody who was, who witnessed the war. He was a Serbian person who actually witnessed the war, and he was taken by the Nazis, and then that person might have reminded him of that situation. So what do you do in that situation? Do I give him medication? No. I'm going to say, okay, well, maybe be sensitive to where you put this person next time. Don't put them with that person repeatedly. I mean, find a way of separate them, and sure enough, that problem might be less. Right? So you have to think about, but it's very hard to elicit that information because the answer that we get, well, we don't know, he's just aggressive. Social environmental factors, too hot of environment, too crowded environment. What's the patient saying? Like, is the person saying that person next door to me is trying to kill me? Well, then I need to think about this as a psychotic symptom. What's triggering it? How do I treat it? And then, of course, caregiver and the stress to the patient caregiver. But we also have a whole set of things we have to rule out. If somebody develops a sudden change and they become aggressive, and then you find out that they're in pain, they fell down and they broke one of their spine, and now they're constant pain, and nobody have treated that pain. I can't tell you how many times I have to give that advice. And actually, I feel like I can't justify my payment. Why are they paying me for this consult? This solution was there from the beginning. So did you think about treating the pain? No. Like, well, go back and treat the pain. Because this person have fractured the spine, and now they're in pain, and you have to treat that. So bladder infection, bladder retention, constipation, all the stuff that could make people agitated. And then we think about, so after we describe, we investigate to find these reasons, then we create a plan and collaborate. It's not me who's going to do all this. I may show up once a month to that facility, so I can't do it all. So I have to create a plan. But instead of me just saying one-liner, say, agitated, aggressive, try this, I have to continue to be in collaboration with team. And we have wonderful relationship with some teams that we work with, all the way to Gray Bruce, Owen Sound. I see them on a weekly basis. We problem solve. Sometimes I see the patient directly through the video conferencing. Sometimes I don't need to because we solve the problem by discussing it. So it's a collaborative kind of work. The other thing that you have to evaluate. So whenever you start a plan, you don't just leave it alone. You ask, is it working? And asking that question, sometimes you just need to tweak the plan a little bit. Okay, so the interventions that, so we start by correcting the correctable. So what we have identified from that framework, we educate, we build capacity so that the person next time they see this presentation, they're not waiting for me to tell them what they need to do. And that happens over time where the team start asking, could this be pain because this person fell down? Like, yeah, you said it. So my work become less, still paid the same, hopefully. I don't want to lose my income, but at least I'm still being useful. But no, it gives me a chance to see other people. So instead of spending hours going through the same situation, now I can say, perfect, you've done the right thing, let's move on to the next situation, right? And then non-pharmacological intervention. So before using meds, how do we find a solution? The bath is too cold. Every time you're trying to give this person a bath, they get upset. Well, maybe warm up the bath or give them hot towel before. There's some solutions that are so logical when you think about it, but for some reason, when you're busy, you're running shortage and stuff, you end up not having the time to even think about logical things. And then drugs. What do we do with medications? So we still prescribe drugs. I'll tell you a little bit about the non-pharmacological intervention. There's a lot of them. So trying to help the person go back to time when they remember very well. So when people are not remembering now, it's probably more comfortable when you say, okay, tell me about that time that you went on that trip. It gives, this is what they call reminiscence therapy. Give people a bit of comfort in an area that they remember well. But also reality orientation, make sure that they know the present, give them calendars, give them details. Activation in general help, social connection with pets or with a person, physical exercise, sensory, such as aromatherapy, music therapy, all these things. Now, all these interventions work, but they work usually at the time that you apply them. They don't cure so you have to integrate them, individualize the plan, and integrate them to what you're going to do. So if the person likes a particular type of music, put them in that good mood before you give them a bath next time to avoid being hit, right? Because if you try to help somebody and they're not in a good mood, they're going to hit you. So what you try to do, play that music. After you see them in a good mood, you can detect that comfort and then gradually get them to. All right, so that's just a summary. Now medications, as you know, the antipsychotic medications are used to treat illnesses like schizophrenia, like bipolar. They have a role in mental illness. We actually had tons of studies to show that they work in people with behavioral symptoms of dementia. In the 90s, millions of dollars were spent on this, and they were used like as a first line. So every time you see somebody agitated, you just prescribe it. And I used to do that. I was a resident. That was what I learned. And then we learned that they increase a lot of side effects, but they increase the risk of stroke and death in this population. So it's not a coincidence. It's actually a real risk. This happened because drug companies that produce the drugs went back and looked at it and say, well, if we compare those who ended up randomly on the drug versus placebo, those who ended up on the drug are twice as likely to have a stroke and about 1.5 times to die. So all of a sudden, we got this black box warning say, do not use these medications. So what happened since that time, we actually went back and studied it, Dr. Vasilev and myself and others. We looked at what happened in Ontario from the time that we got that warning to say, do not use these medications, they can kill people. And we found out that the antipsychotics in this dashed kind of orange went down a little bit, not by much, but did go down. Then other medications start going up without any evidence. So obviously people are desperate to say, well, what do I treat with? You told me not to use this, I'm going to use something else, without any really good studies to show. And even the more disturbing news, that this green line showing using more than one medication kept going up. So people start saying, I'm going to put two medications together, avoid antipsychotics, maybe that will help. Shooting in the dark. We had no clue, right? So we learned that we need to do something, and we need to do something now. So what are we doing about this problem? I'll share with you our contribution from here. So we participated in developing quality standards, but also created care pathways to look at the best possible evidence to treat this. So what can we do? It's not just medication, as a whole spectrum of intervention. How do we design an intervention that will help people without harm? We partnered with national and international leaders in the field of mental health and dementia to actually conduct intervention studies, and I'll show you what we're doing. And then we actually also started looking at, with basic scientists, at the mechanism as well. So on all fronts, creating the standards of what we know today, maybe testing new things and making sure that we have evidence base for future, but also try to understand these illnesses. So this is what I'm going to share with you the next few slides in terms of what are we doing here. So the quality standards for behavioral symptoms of dementia have been published. We were part of that. It's on the website of Health Quality Ontario. It told us what we need to do right. You know, prescribe carefully, start with non-pharmacological intervention, all what I shared with you earlier. So it gave us this requirement for us to do this. So then myself and colleagues from CAMH, we actually created an algorithm. So we went to the guidelines and say, okay, what do we need to tell if we're the experts in the field? And somebody told me, so what do you want me to do? You're telling me that I'm doing the wrong thing. What do you want me to do? So we actually sat with all these experts. We reviewed all the guidelines, and we created a pathway that was published just last year in the Journal of Psychopharmacology. And then we said, well, that's our guess, educated guess. How about studying this and compare this to usual care? So at this point, we have a study called STAN, it's a nice name, Standardizing the Care for Neuropsychiatric Symptoms. It's funded by Brain Canada and by the CABI Center. And it is meant to compare what happens in real life to a pathway of care that was thought through. And we want to see if we're going to be, so we're going to be actually randomizing people. They're both going to get care. One is what they're getting today, one what they're going to get through this recipe. And it's a recipe to answer those quality standards. And London, Toronto, of course, that lead this study, and Calgary and McGill are part of this. So we're part of this multi-center study now. And in London, it's the Parkwood Institute, it's the London Health Science Centre, and it's the McCormick Home is participating. So we actually contributed both hospital, acute, tertiary, and long-term care. So we're really a big part of what's going to happen with this study. The other study that I want to share with you, that we participated in a study called citalopram, they call it CTAD, which is citalopram for agitation of Alzheimer's disease. And that was a study that was very successful, published in JAMA 2014. And this is more trying to help people a bit earlier, you know, not in a hospital unit. We actually did a study, and we showed that it does work. So citalopram helped people with agitation of Alzheimer's disease, but it was associated with two big problems. One, that their cognitive function dropped significantly more than the placebo. And they have a troubling prolongation of this interval, they call it QT, which put them at risk of heart arrhythmia, right? So while we were looking for better news, like to avoid stroke and death from the antipsychotics, and we were happy that citalopram showed its benefit, unfortunately, we learned that it has these two problems. So positive trial, 15 big impact publication, and now so the good news, though, that if you break down the citalopram molecule, it has two components, the L and S isomer. A lot of molecules in nature have this mirror image, so L and S. And the S part of it, which became a drug that's used for depression called S-citalopram, we've been using for years for depression, tend to have no problem with QT interval prolongation. We still don't know if it's going to have cognitive effect or not, but the news so far from the earlier, smaller studies show that it does not have this side effect. So the same authors and us, we went to the National Institute of Health in the States, and National Institute of Aging, and we got funded to run a study. This time we actually decided to do it in the community, so trying to go to prevention, because we learned from the CITAD study that if you give a person with agitation in the hospital or long-term care citalopram, it doesn't really make much difference. It actually works better early on as a more early intervention. So this study, I'll tell you a little bit about what's going to happen in this study. So today, if a person has Alzheimer's disease or Alzheimer plus vascular, they live in the community home, and they get agitated, they can be enrolled in this study. So we'll check on them if they're eligible. We give them psychosocial intervention. You know, remember what I talked about individualizing to say, well, maybe if this person is getting busy in the evening, take them for a walk. So try to find solutions for the individual. And we're going to give that about 3 weeks. And if there's no improvement at that time, we will be giving them either the S-citalopram, this is a drug that I mentioned, or placebo, but we'll continue to give them psychosocial intervention. So we're not going to stop giving them the right treatment. But if they improve, we'll continue to follow them on only psychosocial intervention. And our guess that we're going to have a split of either 1/3, 1/3, 1/3, or we don't know. But it is our hope that psychosocial intervention by itself will help some people that they don't need medications, right? So this is moving the intervention earlier to more of a kind of framework of saying early intervention. So this study is available. We're going to be recruiting people to try to help. and partner with care providers from clinics. So now I want to share with you a little bit about what we're doing for the risk of Alzheimer's disease, right? So this is going to middle age. So we're actually working in a therapeutic brain stimulation clinic. We got a lot of support from our leadership to create this clinic. And we're trying to tackle depression that is not responding to the usual line of treatment. So we have this clinic, it's ongoing, and we're trying to reach a national consensus on how do we treat this entity. We have state-of-the-art facility to provide evidence-informed electroconvulsive therapy. I mentioned the example earlier, but also, you know, with gifts that we got from donors, from the support that we got from capital funding from the hospital, we were able to get transcranial magnetic stimulation, and we started treating people. And then we're also studying something called magnetic seizure therapy, which is using the same magnetic field, but now much stronger, to see if we can treat people like ECT, because ECT is very effective for depression, get people better close to 90% of the time. But it has problem with cognitive side effects. So if we can replace it with something that will have the same effect with less cognitive side effects, that will be a plus. So these are some of the studies that we're doing to tackle the risk for Alzheimer's disease. This is our TMS setup. Again, donations got us this, and the capital funding. This is our ECT. We're really following the best standards. So the practice of ECT in London is the same one that you're going to get anywhere in the world, like Columbia, Mayo. I mean, we compare ourselves to all these centers of excellence. This is magnetic seizure therapy. Dr. Bloomberger holding the coil here. This is the study that we're doing now, funded by Brain Canada, to look at bipolar depression. As you heard earlier, it's a risk factor to develop Alzheimer. So we're trying to treat it without causing cognitive side effects with magnetic seizure therapy. But we also, as I mentioned earlier, partnering with basic scientists to look at how this. So remember I told you that mental illness can be insulting the brain. So one way that it might be insulting the brain is through neuro inflammation. Because we're doing a study today to look at the effect of depression on triggering neuroinflammation in the brain, and that leaves behind a scar. It changes the chemistry of the brain. We're also looking at how ECT and similar treatment affect memory. We're looking at high resolution imaging. But we're also looking at cognition and gait. This is an example here in this building next door, the Lawson state-of-the-art facility looking at PET scanning with MRI to look at neuroinflammation. So we have a study with Dr. Palaniappan. That's going to close up. Actually, we just have the last two required to finish that study. So those who have depression, resistant to treatment, they go to the scanner. We look at inflammation. This is the Robarts group. We're partnering with Dr. Stefan Kohler, Ali Khan, and Palaniappan as well to look at the effect of ECT on memory structures in the brain. And this is actually exciting new development for me because I never thought I'm going to be working with natural killer cells and immune system, but Dr. Mansour Hairafar, who's a professor in immunology at the university, approached me to say, we're looking at the effect of stress on the immune system because we read that stress results in lower function of cells that fight cancer. And so we're actually doing a study with them to explore that. So in addition to our psychosocial intervention that we provide as part of our study, we're also looking at how stress in caregivers who are dealing with illnesses like Alzheimer are affected by this, specifically looking at the function of their cells that fight cancer. So in summary, that mental health issues, both a risk and a core component of Alzheimer's disease, and also that we need to work on all fronts to help people with mental illness when they develop it in the middle age, but also in early stages, and see if we can improve the quality of care for people who are going through the journey. And our partnership has been successful with clinicians and other sites, but also with basic scientists to have a full complementary story. And I'd like to acknowledge patients and families. Without their willingness to participate in studies and be part of all these exciting new frontiers, we would not have been able to do it. Clinical teams and research teams have been wonderful to support us. We have funding support, both from granting agencies, but also donors who came through the foundation and gave us tools that we were able to use to do all this exciting work. Collaborators from everywhere, academic and hospital leadership, that they're here, they're supporting me, that's great. And of course, the communication department for organizing this. Yeah, well, thank you very much for listening. I appreciate it too.
Good evening. My name is Tanya Testa. I'm the chair of the St. Joseph's Healthcare Foundation Board of Directors, and it is my pleasure this evening to thank Dr. Burhan for being here this evening. Thank you so much for sharing all of your insights on Alzheimer's and how it can affect our mental health. I think it was an excellent presentation. Very fast, but an excellent presentation, so thank you. You and I both know that remembering things is hard enough. But depression robs people of the opportunity to remember what they can recall. And those two conditions together present a very unique challenge for our physicians and researchers. And it's a problem that is only going to become more common as the demographics in our country change. While there is unfortunately no cure for depression or Alzheimer's, Dr. Burhan will spend or has spent his life's work trying to look for ways to improve the quality of life. And that's incredible. And of course, they need our help. It was through a grant from the foundation that Dr. Burhan was given to fund the purchase of 2 TMS machines that he spoke about that are giving people with treatment-resistant depression a reason to have hope. These machines were purchased through donations from the public, not from government funding. And donors, as a result, are changing the lives of people in our community with this kind of specialized equipment, your community. And that is amazing, groundbreaking research that is happening here in London. But don't just take it from me. It is my pleasure to introduce Mr. Paul Martin, who is going to share with us a few words on how Dr. Burhan actually changed his life.
Thanks, Tanya, and it's certainly a pleasure to be here and to face this gentleman who has bought into some technology that I originally saw on CBS 60 Minutes, and that's how I found out about TMS. As she said, my name is Paul Martin. I live with my wife and 2 boys in Woodstock, and this work that he has done, I feel so thankful for, simply because my wife, who is 72, Lois, doesn't have dementia, although our family doctor has been tracking to see because she was going through memory issues and things like that. But since she has lived since she was 16 with bipolar depression, and she has some other disorders as well. You listed anxiety, yes, but she also has fibromyalgia, chronic fatigue syndrome, and some other things too. So as people are aging, it gets more and more difficult as these things start creeping into your life. Medication helped off and on, but it's been a lifelong challenge for my wife and our family. And over the years, some of our friends have left. That's one of the problems with mental health. It's really hard to understand. It makes it difficult for your friends to try to be able to maybe help support you. And some of these people that we thought were close friends have left our lives, and it's been difficult. Last year, we got our answer to our prayer, as I said, when we learned about the TMS treatment program at Parkwood Institute. As I said, I saw it showing on 60 Minutes. I've been religiously watching that program since I was a teenager with my father while he was alive. And every Sunday night, I turned to that. And the first thing out of Scott Pelley's mouth was, a new treatment for bipolar depression. Bingo! Was an answer to prayer. We've been trying to find and hope for some new treatment. For 6 weeks in the fall, I drove from Woodstock to Woodstock every day with the mood disorder clinic led by Dr. Byrne, Dr. Ryback, and Dr. Sharma. The whole team there was very caring. Even the receptionist, as my wife was going through the treatment, she started noticing that my wife was improving. It was just astronomical how everything was changing for her. And she started to talk even more on a daily basis. Before the treatments, my wife hardly would be able to carry on a conversation. We just saw our family doctor who administered some routine cognitive testing. He looked at me and smiled. He said, Paul, he says, this is the best your wife has been in a long time. He had a big smile on his face. So we're very, very thankful for that. So the treatments for the TMS lasted for 6 weeks. And as I'm my custom now, every morning I look at Loy and I'll say, any depression or anxiety, honey? And she says, no. I mean, what a relief that is. So now I get to see a woman who's had a wonderful smile when we were younger, and that smile has returned. And she's finally getting back to the person that she was. And she just has started her 4th month in remission. And a week ago, this past Monday, we had our 52nd anniversary. What a wonderful that was, because the first time she hadn't had depression. So that's why I believe it's important when you have experiences like that we believe so much in the work that Dr. Byrne and his group has been involved in. And rest assured, these treatments aren't pie in the sky. The technology properly applied does give an opportunity to be able to help people. So when I learned about the programs and the new studies were only possible because of donations, I decided that I needed to invest my time and some money in this whole new program. I've seen the benefit of specialized mental health care and what it's done not only for Lois, but our boys, because we all have been sharing the problems that she's had. They see her mother is getting better now, and there's hope for them too. We're a happier family now, and we know that there are many families out there with similar experiences who now face a new hope thanks to the treatments at Parkwood. Doctor, thank you so much.
Thanks, Paul. And it's not just Dr. Burhan who is working to change lives. Advancing care, finding cures, and easing the burden of disease is the mission of hundreds of clinicians, researchers, and staff who work here at St. Joseph's and Parkwood Institute, of course. It is also the hope and dream of thousands of families and people like you and I who battle against all kinds of odds like this. So as we continue DocTalks for a 2nd season, we got renewed. We invite you to join us for our upcoming lectures to hear more from these brilliant minds directly. And we have a pretty impressive lineup for you to hear from. We're offering it for free, which is great. So please visit the hospital website or the foundation website to sign up for emails. You'll be notified as soon as registration is open. These fill up quickly, really quickly. I think we were, less than 48 hours to fill this room. So please join us. So that you don't miss your chance. Our next Doc Talk is with world-renowned surgeon and leader in the field of urology, Dr. John Deadstedt, who will discuss kidney stone treatment from ancient times to modern practice and prevention. That's pretty exciting. So that's great. I want to say thank you once again to our corporate sponsor, CIBC. Thank you so much for making tonight's presentation possible. I want to thank all of our individual donors. A lot of this cannot be possible without you, including some of the work of Dr. Burhan, so thank you. You allow us to stay at the forefront of innovation for the residents and patients that we serve. So thank you very much. Travel safely, stay warm. Thank you.